Large cell lymphoma is one of the most common types of non-Hodgkin's lymphomas. It occurs in the United States, over 25,000 newly diagnosed patients each year in the United States. And unfortunately, it's one of those diseases that can become very aggressive. Many times patients present with symptoms. Sometimes they can present with pain, fevers, chills, along with compromised organ function, depending on where the large cell lymphoma is occurring. When patients are first seen in the clinic with diffuse large B-cell lymphoma, the first thing for the clinician to establish is the type of aggressive lymphoma. There are actually several subtypes of diffuse large B-cell lymphoma, and some of those subtypes can behave a little bit more aggressively than others. So when we're seeing patients for the first time, we often go through several frontline treatment regimens. In the United States, I would say the most common of the frontline regimens that we use today is a regimen called R-CHOP. This is rituximab with a combination of chemotherapy drugs that is used usually every 3 weeks for a total of 6 cycles. There is some data with more aggressive or maybe large cell lymphomas that have some different mutational profiles to use regimens like rituximab plus EPOCH chemotherapy. And this is also a combination chemotherapy where we dose adjust each regimen based upon a patient's blood counts. There were some randomized trials comparing these two, and they look fairly similar. But I think in practice, many of us would use CHOP-based regimens for kind of garden variety large cell lymphomas. And if patients have a more aggressive phenotype, a more aggressive mutational profile, sometimes we use regimens like dose-adjusted EPOCH with rituximab. When patients relapse after frontline therapy, there are a lot of treatment options. And to put it in a little bit of a perspective, with frontline regimens, the cure rate, or I should say kind of the long-term remission rate, is usually somewhere around 50 to as high as 70%, depending on the study that you look at. That means that, again, 30% to 50% of patients at some time, unfortunately, will often relapse following frontline therapy. And those relapses can occur usually somewhere between 6 months and 2 years. If patients go beyond 2 years, the odds of relapse really drop significantly. But when patients relapse, the first thing that I do as a clinician is to kind of see what the relapse looks like. If they've had several years of remission, it's very important to re-biopsy the patient and confirm that it still is large cell lymphoma. Sometimes patients can relapse with actually a different type of lymphoma or a different malignancy. Now, assuming that we see a patient in clinic, they've had a large cell lymphoma at diagnosis, they receive a combination regimen, and they relapse in fairly short order, and it's still large cell lymphoma. The standard of care in the United States, if patients have good performance status, would be to use a combination approach with a monoclonal antibody, such as rituximab, with a combination, usually a different combination that they had in the front line. This would include things like ICE chemotherapy, or basically some other regimens like DHAB, sometimes gemcitabine and oxaliplatin, if patients are slightly lower performance status. If patients achieve a remission with one of these salvage options, the next step is always to proceed with autologous stem cell transplant. Now, this is because there have been several studies that have been done in the past that have suggested that patients who achieve a remission with ICE or DAP or GEMOX or one of these regimens, who then proceed to a stem cell transplant, can be cured with things like autologous stem cell transplant. Now, if you may have noticed, I mentioned patients that achieve a remission. So it's imperative that patients have some response to the salvage therapy before they go to transplant. Several trials have suggested that patients who fail to respond to one of these salvage regimens, who then go on to transplant, have really, unfortunately, not good outcomes. So generally, we don't proceed to stem cell transplant unless patients have a good response to their salvage regimen. And so that means sometimes we have to actually do a couple different types of salvage regimens to get patients in that remission to proceed on with stem cell transplant.